This is what they're teaching physician to physician too. So it's, you know, a handful of us yell if I'm over you or under you or wherever you want to be. So if you've got questions, just pipe in. That's from conference. Objectives, indications for placement of central and art lines, mechanical process for the waveforms, and utilizing waveforms to actually find out patient's area of decompensation, particularly in sepsis. So central venous catheterization, why do we put in central lines? So the first one, administration of medications, specifically vein irritating drugs. So you will hear this over and over. A lot of times, especially at night, we might have a patient admitted to a hospitalist that drops their pressure. Levophed, dopamine, something like that is ordered. Then I get a call later. They don't have a central line. And this causes a lot of problems. The reason being, this is a little lady that we had come in. She presented to an outside facility in Swanee, septic, got 2 liters of fluid resuscitation, failed to respond and was started on Levophed to a 20-gauge IV to her forearm. Life Force was called. They picked her up. They did an assessment there. Everything is good. Lift off. Less than a 20-minute flight time, so total looking at IVs about 24 minutes. When she arrived here, the site was red and the IV was infiltrated. Levophed was into the tissue space. And this is what she looked like in 12 hours. All of the skin sloughed off. Vascular was consulted. Their first note said that she would require a forearm amputation. She was also given the appropriate medications in the ER. She was given Regitine to try and control this. Even with that, this was a day later. There's the tips of her fingers. When she was discharged, 3 of her digits had auto-amputated. So, you know, when we talk about Levophed infiltrating and why a central line is a big deal with these medications, this is why people lose limbs to this. So if for some reason a central line can't be placed immediately on somebody that's on a vasopressor, you want to keep as close of an eye. I mean, this was only less than a 20-minute infiltration, and she could have lost her arm. Some really good wound care kept the rest of it, but she did lose 3 of her fingers. So the other reasons, hemodynamic monitoring, fluid resuscitation. So just always handy to know the triple lumens that we put in have 3 ports. One of those is a 16 gauge and 2 18 gauge. So when they talk about doing fluid resuscitation or blood resuscitation, we always talk about 2 18 gauge IVs is better than anything else. The reason for that being, you're running that through 2 18 gauges, but your catheter is 20 centimeters. Plus your port length. So you can't get the same pressure going into a central line that you can in 2 18 gauges with a very short catheter. So it's easier to resus through peripheral or cordis. So they're 18 gauge. It's always nice to know what you're running into, and just poor peripheral access. Complications. The reason that we're careful about placing central lines is overall there's a 15% complication rate. So that includes mechanical complications, putting it in, sticking a carotid artery, putting in an IJ, or dropping a lung while you're putting in a subclavian. Also infectious. A lot of things we're doing now for line management have improved that, but it's still a high infection rate to lines and thrombotic events. So CVP waveforms. We talk a lot about CVP. When I get calls, we talk a lot about what's their CVP running, but you get so much more out of a CVP than a number, and we'll talk a little bit later about why that number means absolutely nothing, and we've proven that. But what you do get is this beautiful waveform that nobody ever looks at. It's a continuously running echo on your patient that we pay no attention to. So this is what a CVP trace looks like. You've probably never even paid attention to it really if this is not what you do, but you have each one of your humps and bumps on a CVP correlates to something that's going on in the heart. So you can see on there, your first one and your tallest wave on your CVP is your A wave. That's atrial contraction. So we think about where a central line sits, just outside of the atrium. Of course, that's going to be your biggest wave because as the atrium contracts, you're seeing the most pressure coming against the catheter from an atrial contraction. If you're looking on air tracings, you have an EKG and then your CVP below. You can find this if there's any question about which one's which we'll talk about with heart dysfunction. Sometimes that's hard. The A wave always comes right after the P wave on an EKG, of course, because your P wave is your electrical activity for your atrial kick, and there's your line. The peak of the wave represents a maximal fill of the right ventricle. So that's also your right ventricular end diastolic pressure. That's a lot of information from a tiny wave on the CVP that we don't look at. C waves is your ventricular contraction. So you think about it as the right ventricle contracts, you're getting some bow back against that right atrium, and thusly it's reflected in touching the end of that catheter. That's also the closure of your tricuspid valve. V wave is your third wave after your first descent, and that's your right ventricular filling and your systemic venous return. And then you have two slopes. Your first one is X, and that's diastolic, and X is systolic and Y is diastolic. Ways to remember this. A wave, atrial contraction. C is closure and contraction, and V wave is venous filling. So understanding this can tell us a lot about a patient's cardiac function. So looking at these waves, if you had a very prominent A wave, what would that tell you about what's going on with your right atrium? Well, you're getting some sort of increased pressure against that catheter from the atrium. Atrium could be dilated. You've got backflow from that valve. Right ventricular dysfunction because you're getting more bow back. Some sort of obstruction to outflow, merged C and V waves, tricuspid regurg. So all of these things, as you look at this, you can learn a lot on a CVP about what's going on with that heart. So while we immediately go to echo and let's get a picture of and let's see what's going on with the heart, you have a continuous tracing of what's going on with that heart. If you're seeing changes on CVP as you're fluid resuscitating somebody, you can literally see somebody's right heart get into trouble by following your CVP waves. So CVP measurement, they say normal is 3 to 8. So we were talking about this the other day. We say that CVP is a measure of volume status. It is not and never has been. The only study ever done that they have proven that 3 to 8 is a normal was in hemorrhaging mares. So horses is the only study that ever said CVP of 3 to 8 indicates volume resus. And why is that? Because CVP is an average of these waves. Our patients don't have healthy hearts. They have diastolic dysfunction. So if you have a peaked A wave, because you have some sort of diastolic dysfunction, your CVP is going to appear higher, and you're getting an average of all of these waves. So what could look normal in somebody with heart failure, running a CVP of 8 to 12, still could be volume under-resuscitated for them because they just have more pressure in that area. What's very important in these patients is a trend. So if you have the ability to hook up a CVP early, you want to do that. Because if we get into problems with urine output, or does this person need more fluid or fluid taken off, the answer is, what has their CVP trend been? Because we ask this question, you hear it all the time, what's their CVP? Oh, I hooked it up and it's 8. It's an idea, but it means nothing to us whatsoever. But if you can tell me, well, yesterday it was trending 3 to 4, now we're 7 to 8, I've got an idea of which way we're headed and what we need. Positioning is key. So, and I do it too, we hook these up and you eyeball, and yeah, and these patients are big and the center of them is hard to find anyway. We eyeball and drop it and that's it. It's actually the 5 centimeters posterior to the left sternal border. So where we have typically mid-axillary line leveled, these is actually not correct, especially on a large patient. When you think about 5 centimeters from their sternal border, if you have a lot of tissue here, as we're leveling to the middle, you're not really getting anywhere near their atrium and fourth intercostal space. So in a typical patient, the transducer alignment at a mid-axillary line, which is where we've all been taught to put these, overestimates by 5. That's impressive. So that's a difference in the CVP between 8 and 12. 8 and 13. So a simple, and that's even with us actually having it to a mid-axillary line and it's well balanced, it can still be off that much because we're not actually following a landmark. So how does that change our resuscitative efforts? You know, somebody levels between days and nights, or we're not finding the same mark on a patient. I'm going to give fluids because somebody dropped, and you're telling me the trend on the CVP is trending down when really it's about the transducer. So as you're teaching people to level these, we've got so many new nurses coming in, how important it is to know your landmarks. Not a center point on the middle of a patient's chest, but, you know, making sure that new preceptees know where these landmarks are. So positive pressure, what does this do to it? Well, we're pushing air into the lungs, we're increasing pressure, so of course your CVP is going to increase. During spontaneous respirations, your interthoracic pressure decreases with inspiration, and that decreases your CVP. So you see a more natural waveform on your CVP, a rise and fall. So if a patient's on the vent, you're always measuring CVP at end expiration because that's what's the most natural. When that patient breathes out, the only thing left that the vent's providing is PEEP. You're getting your most normalized interthoracic pressure at that time. So what's the other thing we do? What's the CVP? 8. With no regard to what's going on with that patient. And really it's about following trends. This is just interesting if you're helping out some residents. A lot of times we want to check to see how fluid responsive somebody is, but putting fluid into people, you can't take it back out once you've done it. We don't see this used enough, and it really is wonderful. So how do we give a fluid challenge without a fluid? Passive leg raises. So if you lay a patient flat, you can either do it with the bed or manually. Raise, the literature varies, one leg or both, but essentially if I lay you flat, pick your leg up to 30 degrees, I'm giving you a 200 ml bolus because of the venous return from your leg. So CVP is leveled. We know what everything looks like. I do a passive leg raise. I'm going to hold it for 30 seconds. If you're seeing a rise in CVP, if you're not seeing a rise in CVP or you see a change in the art line, this patient's likely fluid responsive because you've poured volume back into their midvascular space and seen improvements. They're probably going to do well with fluid. If you're not seeing that, they're probably fluid resuscitated and something else needs to happen. So it's transient and reversible. We can do this as much as we want to. Add some fluid, do it again, repeat without continually dumping fluid into patients that we can't get back off. So this is a tracing. This is out of CCU. It was a post-septic patient. As you can see on the CVP tracing there, if we follow from their P waves, their tallest peak is, of course, their A wave, but it's very peaked. So what would that tell you? Right. And by echo, this patient had CHF and diastolic dysfunction following this. So you can see a nice tracing on the CVP with this, but this is an example of following those A waves, that you can see that that's much more peaked than it should be. You should have a smoother line. So arterial lines is the accepted standard for blood pressure monitoring. And variables change dramatically in these patients. So why do we place art lines? Failure of direct measurement. So PICC lines, mastectomies, places that we don't want to put blood pressure cuffs. We're always wary of a blood pressure cuff on a leg. Very large patients, there are a lot of concerns looking at a lot of patients about, is this actually a good measure of their blood pressure? If we're doing frequent gases, so if we're repeatedly getting into this artery, always a risk of infection with every stick that we do, and a lot of pain for a patient. So sometimes better to be stuck once if you're going to do frequent gases and have something to draw out of. Cardiovascular manipulation, balloon pumps, vasopressors, anything that we're doing to change their cardiovascular status, just provides continuous monitoring, but it also, like CVP, gives us a lot of diagnostic clues. Just as a side note, complication risk for distal ischemia from the placement of an art line is 0.1%, which seems very, very low. But that's the 1 in 1,000 patient that will lose fingers, and you place enough of them and patients will lose fingers. So it's just a reminder that we're very quick to say, let's put in an art line. People do suffer complications from these, not just infection, and we have had patients that have lost fingers from the ischemia. A physics lesson, so we'll kind of skip through this as, it's a little late for a full physics lesson, but if you want slides, you can go back and look at this for your analysis for how this tiny little plastic transducer that we're so rough on works and why. But essentially, it has its own frequency, the transducer does, and it measures the frequency coming through of the arterial waveform. It has its own dampening system that prevents it from overshooting numbers. What we want on an art line is short, stiff tubing. So that's why the tubing from the patient to is the very small, very stiff tubing. What you can do to get a better reading on this is to avoid stopcocks. No extra tubing. We don't want 17 feet of it dangling around. The shorter that you can make the art line, the better it's going to be. Any small air bubble, tiny, tiny bubbles, change that frequency. So it recognizes in the tubing the frequency. That's how we measure blood pressure. Any air bubble in that, any change in that is going to change your resonancy. So small air bubbles are going to cause a falsely elevated, while anything larger is going to cause it to be dampened. Same with a clot. So the square wave and fast flush test, this is my absolute favorite. So I get a lot of calls on my art line's messed up. My favorite one ever, I have to tell this. I got a call to a unit on a post-surgical patient, and she said, my art line's not working. Okay, so when I go in, the nurse isn't with the patient, and I check everything out. Pressure's running about 200 on the art line, has a great waveform, do a square wave test. It's beautiful. Check a non-invasive, they match. The art line's running about 200, non-invasive is running about 194. I'm not seeing exactly what the problem is. So check everything, happy with it, come out, and she said, well, you didn't fix it. And I said, well, I couldn't find what was wrong with it. And she said, well, her pressure's still high. Well, that's the patient. we blame a lot of things on lines. You know, you hear all the time, my art line's running high, and we'll talk about why that is. Or I also got air respiratory therapists are putting in art lines now. They're doing a fabulous job. I got a call from Grant, who I know all of you know on nights. And he said, I put in this art line, and it was thumping, and it was beautiful, and I threaded the catheter, and I'm getting a waveform that's saying like 32/10. It flushes, he's very convinced that he has done something to this line. Well, what does she look like? And he said, well, not good. Does she have a carotid? Well, no, not so much. So it was one of those, I feel like I've done something to the line. In actuality, the patient's more like deceased. So when we have questions about the validity of the waveform, this is one of the best ways to check it. The time between the peaks determines the system's natural frequency, and the height of that tells us how well air tubing is reading. So this is the square wave. As an art line is running across, you do a squeeze to your flush, you're going to get a square on that waveform. The first one, A, is what it should look like. You have your normal, you get a square wave, you have some resonance, a couple. This bottom peak should fall around 0 on your lines on your monitor, not terribly below. You should have one line back, and that's it. If it's over dampened, which means your art line is going to read low, you're going to see a slope. You don't have that nice bounce back, and your square wave slopes off to one side. If it's under dampened, you're going to get lots of resonance once you flush it, and that's going to be reading higher than the person's actual systolic pressure. And then there are things we can do to the actual transducer and the tubing to fix that. If you're getting a good square wave, you're likely have an accurate pressure. So positioning, we talked about, CVP is the most prone to positioning error. We have a lot more fluctuation on an arterial line, but on a CVP, small changes can mean big changes in numbers. And we talked about where small errors in position is disproportionately large errors in data. So how do we make arterial waveforms? The shape is determined by the ejection from the LV, of course, out to the systemic circulation and subsequent runoff. The end of systole is your AV closure, and that's where you see your diacrotic notch. So we talk a lot about on a good arterial waveform, you see a diacrotic notch. That means that you also have to have a good AV closure. And the lowest point, of course, is your diastole. Systolic blood pressures at the radial artery are going to read higher than aortic pressure. So if I could get an actual aortic pressure on a patient, it's going to be lower than what I'm reading on a radial A line. Distal pulses, because of the resonance out into a smaller vessel, have a higher systolic peak and a layered notch, of course, because you're seeing the AV close and time out to the radial artery. So this is why we use MAP. What they found is while the systolic pressure may read higher, your diastolic also reads lower out to radial arteries. So our MAP is our best indication and the closest thing to an actual aortic pressure, and that's why we use MAP rather than systolics. Increases in vascular resistance changes this too. So elderly patients have decreased compliance. If you think about the blood that's hitting these walls, if you have very compliant vessels, say in a 20-year-old, oftentimes you have what people say, oh, it's a dampened waveform, it's a bad waveform. What you're actually seeing is a very compliant and healthy vessel. In our little old greenies with an A-line that are 90, you have stiff vessels, so you get high peaks on them. And we go, oh, that's a great waveform. It's also a really bad vessel. So sometimes poor waveforms just mean healthy veins and arteries. This, if you want to take a look at later, it's a lot of information. It's a busy slide, but some variations that you can see in arterial waveforms that indicate other things that are going on with the heart. To include, if we're seeing AV closure with a diacrotic notch, if you're seeing other valve issues, you can see them in your art line. You can also use art lines for volume assessment. So we've talked about how CVP is not particularly helpful unless you have a trend, but you can also see this in the A line. So delta down. If you have noticed on A lines, if you see a consistent baseline to your arterial line, this usually means a decent volume resuscitation on a patient. When you start to see with their respirations a rise and fall to the base of your arterial line, what you're actually seeing is that delta down, and it indicates that with the change in thoracic pressure, you're actually seeing a change in the baseline on your art line, which means you're under resuscitated. Those patients need fluid. So it's another way to look at, one more thing to look at and to say, should this patient have more or less fluid? Of course, all of this is affected by arrhythmias, lung compliance, and PEEP. So the same thing with CVP. CVP isn't just a number, it's affected by everything that's going on in the heart, every valve closure, every size of the heart. So the same thing with art lines. It's hard to look at delta downs and things like that if you have arrhythmias. Poor lung compliance is a constant change in thoracic pressure. So if you have somebody with fibrosis, that's going to change. You're always going to have a delta. And that's kind of what you're actually seeing, that when you get an art line with that wave, that's an indication of under resuscitation. So what to take away from this? Waveforms help locate mechanisms of decompensation. It's not just about a single number. You have a tool at your disposal to find out so many things about a patient that we underutilize. Especially if you're spending multiple nights with a patient, days with a patient, you can see changes. And we always think about really invasive measures like SWAN's giving us more information than this, but if we're looking at our CVP and art line waveforms, you can really tell what's going on with a patient. As we add pressors to patients, you can see these waveforms change dramatically, because as we're changing the systemic vascular resistance, giving the heart something to work against, you can really see this reflected in CVPs, because if you're putting on a right heart strain based on what you're doing, you can see those changes. So that's something to take back to somebody else. I've started Levofed, but I'm seeing a rise in my A waves. It just helps everyone else to know this heart's under more strain. Different shock requires different endpoints of resuscitation. So hemorrhagic shock versus septic shock. These help us find our endpoints. We're talking more now about with sepsis hitting them very early with lots of fluid and slowing things down. We tend to over-resuscitate for longer than we should in septic patients. If we are watching CVP trends and seeing what we're doing to the different portions of the heart, it helps us find endpoints on resuscitation. And these numbers reflect the body's ability to meet metabolic demands. There is no threshold blood pressure that defines adequate organ perfusion. So we consistently say anything less than 65 is pathological, so that's where we tend to run our maps. But what we're finding out now is for our patients that are coming in with very chronic hypertension, whose blood pressures at home run 180, a map of 65 is not adequate for them. Their organs are used to much higher pressures than that, which is why we're still seeing end organ damage even though we're achieving maps of 65. So that goes back to getting a good history on a patient. If we can find out what blood pressures have been running at home, it helps to get an endpoint target for their map. So knowing that somebody, feeling comfortable and being tricked into knowing that a CVP is a certain number. Oh, I've resuscitated to 8 and everything's good. It may not be good for that patient. To say that I have a consistent map of 65 on this patient still may not be enough for them, still may see kidney damage. The accurate assessment of intravascular fluid status is the essential part of critical care management. It is the biggest thing that we do. It's what keeps organs running. It's what changes our management and tells us where we're going with a patient. Goal-directed fluid management can facilitate resuscitation of a hypovolemic patient, reduce the risk of fluid overload, reduce the risk of insidious use of vasopressors, inotropes, and improve clinical outcomes. So these two measures that we use, art line and CVP, is what completely drives our sepsis care. So the more we know about the waveforms and how we're using these numbers, the better we're going to do volume resuscitating and not over resuscitating these patients. Yeah.